Okay. Good evening, students. So, as you all know, today we are here to discuss the oral surgery portion of the INICET, which just took place in November. So, we'll be discussing the questions that were asked. Now, if we reflect at the paper and we see that it was a easy paper.
Good evening, students. So,
It was a relatively easy paper, and the again, what I have been telling in all my sessions in the class as well, what we all need to just focus is on reading the questions carefully and not jumping to conclusions without reading the questions carefully or reading the complete set of options that have been provided to us. All right, so let's start with our first question. The first question is to reduce the bilateral gonial flaring in symphysis fracture where plating should be done. So before we look at this question, let's try and understand what is the question trying to ask us. Now, sometimes what happens, especially in symphysis fracture, I'm drawing a symphysis fracture which has a lingual splay. Now, what does lingual splay means? At the lingual cortex, both the fracture fragments have moved apart. They have moved apart. All right. Now, due to this lingual splay, the angle of the mandible or the gonial region of the mandible will be pushed outwards. All right. So, there will be an increase in intergonial distance, also known as bilateral gonial flaring. That means the gonial region, the angle region will protrude outwards. All right, it will protrude outwards. Now, we have to reduce this. What we have to do is we have to reduce this so that we get back the original intergonial distance. Now, how is this possible? This is possible by doing a certain things. We will first, what we'll do is we will do the plating, and while the surgeon is plating, the operator will give bilateral gonial pressure so that the lingual cortical plate is reduced. So that what is happening? We want lingual cortical reduction. Lingual cortical plate reduction. This is our aim. This is our aim to achieve lingual cortical plate reduction. Now, how is this achieved? This is achieved by putting a plate on the labial aspect. We put a long span plate, usually extending from the first premolar to the first premolar, so that what the plate does, it gives a hugging effect to the symphysis. It gives a hugging effect to the symphysis, so it will reduce your lingual cortical splay or lingual cortical separation that has taken place. All right, and while doing so, the assistant puts pressure on the angle region bilaterally so that we achieve lingual cortical reduction. Now we will see our options. Let's come to our options. So the first option we have is labial aspect, lingual aspect, plating done both on labial and lingual aspect, and closed reduction. So as we all know that the correct answer is plating on the labial aspect. Please remember, do not confuse that if there is lingual cortical separation, we will do lingual plating. No, that is never done. We never do lingual cortical plating. We always do the plating on the labial aspects. Alright, we always do the plating on the label aspects irrespective of the fractures. You will never go onto the lingual side of the mandible and do any plating. Alright, so your next option, lingual aspect, is incorrect. Both lingual and labial plating is also incorrect, and closed reduction. You will never be able to achieve lingual cortical plate reduction with closed reduction, because you need something, you need a direct fixation device to hold the reduction in place. Even if you achieve it by closed reduction by compressing or putting bilateral angle pressure, but again it will snap back, because you need a direct fixation device to hug the mandible and help in reduction staying in its anatomical position that you have reduced it to, so that it does not go back. Alright, so that there is no further opening up of the lingual cortical plate. Now let's come to the second question. Medial displacement of condylar head during subcondylar fracture is due to the action of which muscle? Again, this is a repeat question, a direct question, straightforward question. Now, just so that you all can revise, condylar fracture. Just that you all can revise what is the attachment at condylar fracture. Now we all know that the condyle has attachment of the lateral pterygoid muscle. Alright, condyle has attachment of the lateral pterygoid muscle. Please remember, the only muscle of mastication which has its attachment in the condyle or in the TM joint capsule is the lateral pterygoid. Alright, so if there is a fracture of the condyle, the lateral pterygoid muscle action pull will cause displacement. This muscle will cause displacement of the fractured condylar segment. Alright, the lateral pterygoid muscle will cause displacement of the fractured condylar segment. And the direction, please remember, this is also a question. The direction of displacement of condyle due to lateral pterygoid action. What is the direction? It is anteromedial. It is anteromedial. So this is also a question. The direction in which the condylar head will be displaced due to the action of lateral pterygoid. Alright, the direction is anteromedial. Now let's look at our options. It is a straightaway question. So the options are medial pterygoid, option A, option B is lateral pterygoid, C is buccinator, and D is masseter. So our answer is lateral pterygoid. This is our answer. Option B is our answer over here. Alright. So two aspects, which muscle causes displacement and the direction of displacement. Both are questions, both are repeat questions and are important points. Now coming to question number 3. Now the question asks, common site of CSF rhinorrhea in middle third facial fractures. Now please understand that there can be another version of also of this question. Right now the question is asking you particularly about CSF rhinorrhea. Now what is CSF rhinorrhea? CSF rhinorrhea is CSF leakage from the nostrils. Okay, CSF leakage from nostrils. So CSF rhinorrhea, as I've already told in the classes and in my recorded lectures also, that CSF rhinorrhea is usually seen in middle third facial fractures. Now your middle third facial fractures include Lefort 1, Lefort 2, Lefort 3, zygomatic complex fractures and your orbital floor fractures. These all come under middle third facial fractures. Now, amongst all of this, CSF is most likely to be seen in Lefort 2 and Lefort 3. Alright, this all we are aware of. Lefort 2 and Lefort 3 are most likely to show us CSF leak. Apart from that, NOE fractures, that are naso-orbito-ethmoidal complex fractures, can also present with a CSF leak. Now, if the CSF leak is due to middle third facial fractures, it is always due to the fracture of cribriform plate. It is always due to the fracture of cribriform plate. Okay. Now, so here the answer, the options are tegment tympani, option A, option B frontal bone, C cribriform plate, and D inferior meatus. Please do not confuse between frontal bone and cribriform plate. Alright, the cribriform plate it is a part of your anterior skull base. Alright, cribriform plate is a part of the anterior skull base. Frontal bone spans your entire forehead region. Alright, so please do not confuse. It is not frontal bone. The answer is cribriform plate. Alright. Now, there are 2 points that I would like to discuss here. There is a structure known as tegment tympani. Alright. So, this structure is present between your middle ear cavity and the middle cranial fossa. Alright. It is present between the middle ear and the middle cranial fossa. Now, whenever there is fracture of tegment tympani, it will cause CSF otorrhea. It will cause CSF otorrhea. Now, CSF otorrhea is nothing but CSF leakage from ear. It is nothing but CSF leakage from ear. Alright. Now, there can be another aspect to this question. The question can be framed in a different way also. It can say that the question can also be framed in a different way. Please try to understand how your answer will change. It's if the question says common site of CSF leakage, common site of CSF leakage from mid facial region. Alright, common site of CSF leakage from mid facial region. Now, please understand, 2 words have changed over here. Instead of CSF rhinorrhea, we now have CSF leakage. Alright, instead of CSF rhinorrhea, we now have CSF leakage, and instead of mid facial fractures, we have mid facial region. Alright, so there is the question. If you look at it in the first go, you will feel the answer to this is cribriform plate, because you would have in being in a hurry or not trying to read and understand your question, everyone will end up marking cribriform plate for this question as an answer, which is incorrect. Now, they have not mentioned where is the leakage from. Alright, it can be CSF rhinorrhea, it can be CSF otorrhea. Now, what they have mentioned is from mid facial region. Mid facial region. Now, if you look, that if you see that the cribriform plate is forming the base of your anterior cranial cavity, anterior cranial fossa, all right, but your tegment tympani is present in the mid facial region. The tegment tympani is a structure in the middle ear which separates the middle ear from the middle cranial fossa. So that tegment tympani is a structure present in the mid facial region, whereas your cribriform plate goes higher up. If you see the location of tegment tympani on yourself, tegment tympani and cribriform plate. So the if you have to decide between these two structures, what is present in the midfacial region, then your tegment tympani is present in the midfacial region. So the answer to this question will become tegment tympani. All right. So again and again, I always tell you, I always focus on telling all of you that whenever you're reading your questions, it might in the first glance look like, okay, we have seen this question, this is a repeat, and this is the answer. No, please take out 30 seconds. I know we all want to complete all the questions, and we are, it is very natural for all of us, for you, for me, to be in a hurry to read the question, mark the answer, and move on to the next question. But that is where blunders happen. You have to see, you have to read, and you have to now understand how the question has been changed or twisted so that you end up making a mistake. This is what we don't, this is a trap for us. We don't have to fall in that trap. You have to see what is the change in the question, what is it trying to say, are there any words which have been changed, or are there any points. Now the problem here would be the options will remain the same, but the framing of the question has been changed, hence your answer changes. But we'll be in a hurry and we will mark cribriform plate. Okay, so this is one point that I want you to focus on. Please, I always say this repeatedly in my class, in my lectures, please read your questions, look for what the question is trying to tell you and what are the options. Read everything carefully and then take 2 minutes to think, because you all have read, you all have worked hard. ऐसा नहीं है नहीं आता है, you all know everything, but the only thing that matters on the day of your exam is reading the question and coming to the correct answer. All right, so now we'll move to the next question. The wall which most commonly collapses in an orbital blowout fracture. This is again a repeat question, a very straightforward question. So the options are option A medial, option B lateral, option C roof, option D floor. So here the answer is option D, that is floor. Now again, few important points which I tell in my class and in my lectures as well. Most common orbital wall to fracture. Most common orbital wall to fracture is always the floor. And another question might be the weakest wall of orbit. This is the answer here is medial. Again, please do not confuse. The most common orbital wall to fracture is the floor, and the weakest wall of the orbit is the medial wall. All right. Now, let's come to question number 5. The given instrument works on the principle of class 2 lever, option A, option B wheel and axle principle, option C wedge principle, and option D is class 3 lever principle. Now here we have to identify the instrument and see where our answer is. Now if you look at this, This is a Winters cross bar elevator. This is a Winters crossbar elevator. Okay. So now Winters crossbar elevator, amongst the given option, it works on the principle of wheel and axle. It works on the principles of wheel and axle. Now let's see examples. Let's see the examples on with examples of instruments which are based on this wheel and axle principle. So your forceps, your Winters crossbar, and Cryer's elevators. These are all examples of wheel and axle principle. Now we will quickly revise a few points. The mechanical advantage of Winters wheel and axle principle is 4.6. This is a question point, direct question. The mechanical advantage is 4.6. Now, just to revise, just to go back, what is the wheel and axle principle and how does it work? So we all know automobiles, we all know cars, they have an axle and the axle is connected to wheels. All right. So the axle moves. That's why the wheel moves. The axle moves, hence the wheel moves. Similar principle is also put to use while we are doing our extractions, either with help of a forcep or with an elevator. Now in wheel and axle, what is exactly happening is, there is an axle and there is a wheel. So the radius of the axle is the inner one, which is the smaller radius, because there is a movement at the smaller radius at the level of the axle. Hence, there is a movement at the wheel and the radius of the wheel is larger. Alright, because there is movement at the axle, there is movement at the wheel, but the radius of the axle is smaller and the radius of the wheel is larger. Now, I have explained this previously as well. If this is the tooth, and this is our forcep. Okay. If this is the tooth and this is our forcep. Now let's also draw Winters crossbar. Okay. So if there is a movement here, if there is a movement where we have caught hold of the tooth, if we are doing rotation movement there, then there is subsequent rotation over here. At our effective arm, we have held the instrument from a distance. The rotation is taking place at the axle near the tooth. All right, and this is the radius of the wheel and that is the radius of the axle. All right. Similarly, when we are using our Winters crossbar, we use it in rotatory motion. All right, we use it in rotatory motion. We this bar here, we hold it like this and we use it in a rotatory motion. So there is some movement at the tip of the elevator which happens at a smaller radius. So this becomes the radius of the axle, and here there's a larger diameter movement taking place. So this becomes the wheel. All right, that becomes the wheel. All right, so I hope this is clear. Now we move on to our next question. Identify the wiring technique from the given image. So the option A is Ivy eyelet, option B is Gilmer, option C is Ridson's, and option D is Kazanjian button. So the correct answer here is Ivy eyelet. Sorry. So the correct option here is Ivy eyelet. Okay. Now I want all of you to understand Ivy eyelet. I have a few diagrams with me so that you can understand, and whenever there is a picture of Ivy eyelet, you can easily mark the correct answer. All right. Now, if you see here, I'm going to zoom this out a little. If you see here in picture A, if you see, there are small loops. There are small loops. All right. So you take a wire, you make a loop, twist that wire, and then you make the wire enter from the interdental space of two adjacent teeth. All right. You make the wire enter like, all right, you make the wire enter from here. Okay, where I've marked. Then you take the wire and you rotate them back. You take the two wires, rotate them back, and you get out the wire from the medial aspect of the anterior tooth and the distal aspect of the posterior tooth. Alright, you don't need to go into the technicalities. I'm just trying to explain you what is Ivy eyelet wiring, how it is done, so that if you're asked in the future, you can mark it correctly. Alright, now what is done, you introduce the distal wire in the loop and you tighten your wire here. Alright, so what you basically see is, you will just see those eyelets. If you are given a photograph or if you're given a clinical picture, you will just see these eyelets. You will just see these eyelets. All right. Now, what is the use of these eyelets? Like you can see in picture B here, you can introduce your intermaxillary fixation wires through these eyelets. All right. You can introduce your intermaxillary fixation wires and tie them how they have been tied in picture C. All right. So you have given an Ivy eyelet wiring, both upper and lower jaw. Then you take another set of your stainless steel wires, straightened wires. You pass your wires through these loops, through the maxillary eyelets and the mandibular eyelets, and you just tighten those wires. So you will achieve intermaxillary fixation. You will achieve intermaxillary fixation. All right. So there's another image which I have, which explains the steps which I just explained to you. Both ends pass through an interdental space. All right, you make an eyelet. If you see here, you make an eyelet, you twist it, and then you take the both ends of the wire and you pass that through an interdental space. End brought buccally from mesial tooth and end brought out buccally from the distal tooth. If you see these arrows here, all right, if you see these arrows here, all right. So students, if you have any doubts, you can ask me in the live chat below. All right. So now the third step is, both ends are brought out buccally. Both ends are brought out buccally. And then after that, you come to this picture. All right. So the distal wire is passed through the eyelet. Only the distal wire, please remember, only the distal wire is passed out through the eyelet. And then you tie the two ends together. The two ends are twisted together with the help of a wire twister. All right. And the wire is cut. Wire is cut and tucked. All right. So you will just see those loops. You will see prominent round loops or eyelets. This is your IV eyelet wiring. Now just quickly to revise, all right, just to revise quickly, although I have taught this before as well, just to revise quickly, what are the different types of wiring? So your Gilmer wiring is direct method of wiring. Just to quickly revise, all right, then your next is IV eyelet wiring, which we just saw, all right. Now Ridson wiring is, there is a special indication for this. It is indicated for minimally displaced symphysis fractures. Minimally displaced symphysis fracture where entire set of teeth are intact, where entire set of teeth are intact. And then there is your kernel stout wiring, which is your multiple loop wiring, loop wiring. And there is Erish arch bar, which has the maximum strength. This has the maximum strength for IMF. All right. So this is just a quick revision about different methods of wiring and what are they, if there is special indication for them, or what is the other aspect to it. All right. Now we'll come to the next question. A 20-year-old woman presents to the clinic with a 6-month history of pain over the TMJ and reduced mouth opening. On examination, tenderness of TMJ is seen. Radiographic image shows resorptive changes in the condyle. Identify the condition. Okay, so this kind of a question, again I want to tell you, this kind of a question is a new question. All right, there's something, it's talking about something that is new. Now this type of questions you can actually attempt through elimination method. You can actually attempt through elimination method. Now you do not need to directly jump onto an answer for this question. You can read your option one by one and try to correlate if it is matching with the description given in your question. First of all, we will see option A, that is disc displacement with reduction. All right, now with this displacement, patient will have pain over TMJ. Yes, definitely. There will be reduced mouth opening. Yes, definitely. But disc displacement will also have a clicking sound. All right, it will also have a opening click. All right, the disc displacement with reduction will have an opening click, but your question does not mention click anywhere. All right, it does not mention a click anywhere. So this option is ruled out. Now coming to option B, that is idiopathic condylar resorption. So idiopathic condylar resorption is that when the condyles just start resorbing on their own without any specific cause or any specific etiology. All right. So, and what you'll see on a radiograph for idiopathic condylar option is that you will definitely see, whether on an OPG or CT, you will definitely see condylar resorption. All right. And since the condyle is resorbing, patient will definitely have pain. There will be reduced movements in the joint because now the condyle does not have a contour, it's resorbed. So the movements will be affected. Hence, patient will have reduced mouth opening. So yes, this somewhat seems like our answer. But before marking this answer, we have two more options left and we have to see them as well. Now, option C is a fractured condyle. Now, fractured condyle can be, the question mentions 6-month history of pain. Now, fractured condyle, if it is 6 months old, first of all, it will be malunited. All right. And even if it is a fractured condyle, there will be pain, there will be reduced mouth opening, but the chances of it being resorbed will be very, very less. Okay, chances of it being resorbed will be very, very less. And in a fractured condyle, the radiograph image will not show resorptive changes. It will show a clear cut fracture line. It will show clear cut fracture line. So we rule out option C as well. Now coming to option D, that is TMJ dislocation. Now, if there is TMJ dislocation, the patient will have maybe reduced mouth opening, will have pain, but on the radiograph you will see that your condyle is displaced and it is lying anterior to the articular eminence. Alright, it is lying anterior to the articular eminence. But here the radiographic picture is showing us resorptive changes. So your option D is also ruled out. Hence the option to this question will be idiopathic condylar resorption. This is the answer. So it does not necessarily mean that in case if you're given a new question or if there's something new for you, I would still suggest all of you to go through the question, make notes of the points that is trying to tell you, and one by one start looking at your options. Here you have to think a little retrograde. How you do the eliminations, you now have to think retrograde. Usually we read the questions and try to, if you know you've understood the question, you try to find out the answer. All right, but here there's something new given in the question. Now you want to find out the option. When you want to eliminate, you go to the option, and when you, like we came to the disc displacement with reduction, try to go through the clinical presenting features or if any radiographic features of that option, and then try to match it with your question. So this is how we ruled out option A, C and D and arrived at answer B as our option. Alright, so if there's something new that is presented to you, you have to try to recall the clinical features or whatever the clinical aspects or the radiograph image present or the most likely features that would happen in the options given. Alright, now we'll move on to our next question. Coming to question number 8, it says for extraction of mandibular third molar. For extraction of mandibular third molar, LA was injected in a known diabetic patient. After injection of LA, he complains of double vision. What is the most probable cause? Okay, so this is again a question where mistakes have been done, and so I now want you all to please try and understand what I'm trying to tell you. For extraction of mandibular third molar, for mandibular third molar, what are the nerve blocks you're going to give? You're going to give inferior alveolar nerve block, you're going to give lingual, and you're going to give long buccal. Okay, now a known diabetic patient. All right, a known diabetic patient can either have hyperglycemia or the patient can have hypoglycemia. All right, so these are the two most common things you will encounter with a diabetic patient. Either the patient will have hyperglycemia or hypoglycemia. Okay, and he complains of double vision. He complains of double vision. Let's look at our options. Option A is hyperglycemia, option B is hypoglycemia, option C is syncope, and option D is inadvertent injection into infraorbital foramen. Now, this is the mistake that you will make without reading the question, बिना आगे पीछे का सोचे, without thinking about what other aspects the question can have, you will end up marking this option. Diplopia हो रहा है, तो it may be related to infraorbital foramen, so we will mark that we have injected LA into the no, this is absolutely wrong. It is absolutely wrong. When you are extracting a mandibular third molar, you will never, even inadvertently, you will not inject LA into the infraorbital foramen. You will either give, like I told you, an inferior, you will give all these three blocks: inferior alveolar, lingual, long buccal. There is no chance that you will deposit LA in the inferior alveolar, infraorbital foramen. There is absolutely no chance. So if you just see the double vision and don't pick out the other keywords from the option and end up marking this as your answer, inadvertent injection into the infraorbital foramen, you will obviously end up losing your precious marks. All right, you will obviously end up losing your precious marks. Understood? Now the other three options are very close, and how do you arrive at your answer? Now the thing is, a diabetic patient, like I told you, will have either hyperglycemia or hypoglycemia. All right. Now again, if the patient is having double vision, that means that the patient is having syncope. The patient is having syncope. All right. Now again, we have two very close options to decide from. It is very unlikely if a patient will have hyperglycemia, the patient will not have syncope, the patient will not have double vision. Okay, the patient will not have syncope, or the patient will not have double vision in hyperglycemia. All right, so you rule out hyperglycemia as well. Now you're left with two options, and two are very close options. Option B, hypoglycemia, and option C, syncope. All right, now for a diabetic patient to say that the patient has syncope is a very general statement. Syncope anyone can have on the dental chair: a non-diabetic patient, a diabetic patient, a healthy patient, a child, a adult, a pregnant female. Anyone can have syncope. But if your answer mentions, if your question, mentions diabetic patient, then what is the reason the diabetic patient will have a syncope? Is hypoglycemia. The cause behind a diabetic patient having double vision, having syncope, feeling dizzy, fainting on your chair, the reason would be hypoglycemia. The reason would be hypoglycemia, and this is your answer. Because if he's having syncope, then the reason behind syncope for a diabetic patient will most likely will be hypoglycemia. So you cannot mark syncope as your answer, because it becomes a general statement. Because syncope anyone can have, but if your question specifically asks about regarding a diabetic patient, then syncope is going to be due to hypoglycemia. I hope this question is clear. This question, the options were close, and you have to mark you have to come at your answer after understanding all aspects given in this question. All right, now coming on to the next question. An athlete with a habit of chewing gum presents with an asymptomatic swelling in the preauricular region. On palpation, bony exostosis is palpated and seen on a PA cephalogram as well. What would be your diagnosis? All right, now please understand, habit of chewing gum. That means the patient frequently or chews gum a few times a day. All right, with an asymptomatic swelling present in the preauricular region. That means there is no pain, there is no other sign or symptom associated, but there is a swelling in the preauricular region. All right, and on palpation, bony exostosis is palpated and is seen on a PA cephalogram as well. What would be your diagnosis? Now coming to option A, again in this question we will again use our method of elimination, and I'll tell you how now as I explain you further. So This is a new question, and the options given in the options also, you may not be knowing everything. Now, the option A is benign mesenteric hypertrophy. Now, what is mesenteric hypertrophy? That the masseter muscle is enlarged in size beyond beyond its normal size. All right, benign mesenteric hypertrophy. Okay, this is what you understand from the first option. Coming to the next option, that is option B, traumatic myositis ossificans. So, traumatic myositis ossificans, what will you have? You will have a history of trauma. Okay, and traumatic myositis ossificans is painful. It is a painful condition. So, but your question mentions asymptomatic, hence this option has been ruled out. Okay. Now coming to pleomorphic adenoma. Coming to pleomorphic adenoma. Now pleomorphic adenoma can be painless, or there may be pain sometimes, may or may not be pain. But with pleomorphic adenoma, one very classical sign or symptom that you will find out is raising of ear lobule. Raising of ear lobule. Okay. So this is a symptom, or this is a sign that you will find out. So even this option has been ruled out. Although the swelling is painless, there may be pain presentation sometimes with pleomorphic adenoma, but the ear lobule will be raised. The ear lobule will be raised. So this is a sign, this is a symptom. All right. So hence this option also has been ruled out. Now coming to option D, that is MPDS. MPDS is myofascial pain dysfunction syndrome. The condition itself mentions pain in its name. So again, this is a symptom. So this option also has been ruled out. We have ruled out option B, C and D, and the answer becomes benign mesenteric hypertrophy. The answer becomes benign mesenteric hypertrophy. Now, I just will not go into the details of benign mesenteric hypertrophy. Alright, I'll just tell you the clinical. I have a few images with me. I'll just tell you the clinical picture and its radiographic presentation. So I just want you to all to concentrate here. If you see this picture, and if you see the right side of the patient, he's having a proper bulge here. This masseter region, he's having a proper bulge. Okay. So the patient will present with a swelling. This looks like a swelling, but this is actually hypertrophied masseter muscle. It is hypertrophied masseter muscle. Okay. Now, if you see the scans of this patient, so this is not a PSA cephalogram, but this is a MRI. So even if you see here on the MRI, there is a bulge. It'll give an impression of that there is either some growth or there is some, tissue growth. In MRI, obviously, it is more for a soft tissue. It's a soft tissue imaging. You won't see exostosis, but if you see a ceph or any other imaging, it might give a feeling that there is something protruding from the bone, or there is a exostosis kind of an image, but there'll be some abnormality, some increase in size on your imaging, any imaging modality. Now I would like to zoom here. If you see the size of the masseter muscle here and you compare it to the size of the masseter muscle, all right, you see that the masseter on the right side is hypertrophied. It is more bulkier than the one on the left side. Now why is this happening? Patient is a habitual chewing gum chewer. All right, he's chronic chewing gum chewer. What is the patient doing most probably? He's chewing gum from one side and continuously chews gum from that one side for hours and hours together. So what has happened? That has caused hypertrophy of the masseter muscle. Now very simple point to make you understand this. If you probably, if you go to the gym and you weight train from only your right hand and don't do any weight training from your left hand, you just do weight training from your right hand, what will happen? You will develop muscle bulk in your right hand. So similar thing is happening over here. The patient is probably chewing gum from only one side, from the right side or the left side, and due to that the muscle is getting trained more, it's working more than its opposite side, resulting in its hypertrophy or developing more bulk. All right, this is the concept behind this condition. Now we move on to the next question. After performing gap arthroplasty for TMJ ankylosis, which of the procedures will help in functional rehabilitation of the patient? Now you have to restore the function of the patient after gap arthroplasty. Now coming to our options, option A is fat grafting, option B is physiotherapy, C is temporal fascia lining, and D is placing a suction drain. Now amongst the given options, option B, physiotherapy is the answer. Now functional rehabilitation is physiotherapy, that means active mouth opening exercises. You have to get back the function. You have to after gap arthroplasty, because patient before prior to gap arthroplasty did not have mouth opening, you have to get back the patient to active mouth opening so that reankylosis is prevented and patient gets back to normal functional loading, that is getting back to normal diet faster. Now coming to the other options, here we'll quickly revise. What is fat grafting for? Fat grafting is to prevent heterotrophic bone formation. Heterotrophic bone formation and to prevent reankylosis. And to prevent reankylosis. And to prevent reankylosis. Now temporal fascia lining. What is temporal fascia lining? It is used as an interpositional material. It mimics the disc and it also prevents reankylosis. Now placing of a suction drain. We all know when we are operating on the temporomandibular joint, it's a closed joint cavity, it's a closed joint space. All right, so once we are closed, once we are done giving skin sutures, there will be some blood which will get collected in that cavity. So we place a suction drain. We place a suction drain to prevent hematoma formation and to evacuate blood from the joint cavity. We put a drain for a few days so that whatever blood is there gets collected in the drain and does not accumulate in the joint cavity, leading to a hematoma. All right. So here the option is option B, that is your physiotherapy. Yeah, Chetan, why not hyperglycemia in the diabetic question? See, hyperglycemia will not give the patient a double vision. Okay, double vision will be because the patient is going into hypoglycemia, and hypoglycemia, due to hypoglycemia, the patient will become dizzy, will be going into syncope, so the patient will start having double vision. Hyperglycemia is not going to give patient double vision. All right, I hope that is clear, Chetan. Let's come to the next question. Which rib is the most preferred for harvesting a costochondral graft? Option A is the second rib, option B is the fourth rib, option C is the sixth rib, and option D is the 10th rib. All right, so here the answer is option C, that is your sixth rib. Now most commonly used ribs are fourth, sixth, and seventh rib. All right, the fifth and sixth rib are used in male patients and sixth and seventh rib are used in female patients. Why the lower ribs are used in female patients? To hide scar in the inframammary crease. to hide scar in the inframammary crease. Now, another tip that I would like to give all of you here is, if sometimes 5th, 6th, 7th rib, all of these are mentioned consecutively in your options, still please go for 6th rib, because it is common to both the male and female patients. All right. If in your options it's given as 5th, 6th, 7th and 8th rib, still please do not get confused, because that is the rib that is commonly used to in male and female patients both. All right. Hence, please go or stick to the 6th rib as your answer. All right. Now, coming to the next question, that is identify the image given below. It's a repeat question, and we all know that this is a piezo insert. This is a piezo insert. All right. There's nothing known as a cobalt insert or a titanium insert. Yes, but there's something known as a sinus lift insert. So the next picture that I'm going to show you is that of a sinus lift insert. If you carefully look at this, there is a disc-like structure present over here. All right. There's a flat disc-like structure over here. All right. This one. Flat disc-like structure. This is a sinus lift insert. So what is this? This is actually the disc. The face of the disc is a non-cutting. The face of the disc is the non-cutting face. What is it used for? When we're doing sinus lift, to push the mucosal lining or the sinus membrane superiorly, or to push it inwards further into the maxillary sinus. This one is a sinus lift insert. If this is given instead of that picture, your answer will become a sinus lift insert. All right. Okay. Question 13. The most commonly fractured face of fractured bone of the face is, options are option A mandible, option B nasal bone, option C frontal bone, option D maxilla. So the answer here is nasal bone. This is the most commonly fractured bone, and mandible is the second most commonly fractured bone of the facial skeleton. Now, the best way to remember this is, anything on your face that has a projection to it or is prominent is most likely to get injured. All right. That's why if you see on your face, the nose has a projection. All right. It is more prominent than all the structures. That is why the nasal bone is the most commonly fractured bone. So this is how you can remember it. Now coming to question number 14, that is injection of local anesthetic solution in which of these areas will cause facial nerve palsy. All right. Option A is pterygomandibular space, option B is submandibular gland, option C is parotid gland, and option D is buccinator. All right. So the correct option here is parotid gland. Now we all know that the nerve, when it exists from the stylomastoid foramen, it enters after which it enters the parotid gland, and due to the facial nerve trunk, the parotid gland is divided into a superficial lobe and a deep lobe, and then the facial nerve branches into its 5 terminal branches at the inside the parotid gland. All right. So if during your inferior, especially your inferior alveolar nerve block, all right, if you by mistake enter the parotid gland, then the patient will have transient facial nerve palsy due to irritation of the facial nerve or due to deposition of local anesthesia around the or in the vicinity of the facial nerve. All right. Now another thing that can happen with an inferior alveolar nerve block is trismus. It is trismus. All right. Now why this trismus happens? Due to injury or irritation of medial pterygoid muscle. Due to injury or irritation of medial pterygoid muscle. ठीक है? Please remember, trismus is not due to injury or irritation of the buccinator muscle. It is due to the injury or irritation of the medial pterygoid muscle. Alright? So during inferior alveolar nerve block, you can cause a transient facial nerve palsy or facial palsy, or you can cause trismus. So that is due to injury or irritation of medial pterygoid muscle and not your buccinator muscle. Alright? So with this, we come to the end of our discussion for today. Now, the only tips and advice I would like to give you is, please try and read your questions and your options carefully. Even if you don't have an idea of what is being asked in the question, you can still go to your options one by one, try to recall whatever you have read about that option. And in case you have no knowledge, just keep that option aside for 2 minutes. It is most likely that through elimination or by recalling the clinical features or related aspects of those options, you will be able to arrive at your answer. Alright, so I would like all of you to please practice this before your exams, that you read your question. In case you do not understand anything about the question, read your options one by one, give it some time, try to recall everything that you have read about that option, try to relate it to the question, and then try and come at a conclusion whether you want to eliminate this option or you can consider this as an answer. Alright, apart from this, what I always tell all of you is, please pick out keywords. Please try and judge what specifically the question is trying to ask you, especially like for the diabetic question. It is asking you that it's a diabetic patient and he develops double vision. So if it is a diabetic patient and the options are given in terms of hyperglycemia and hypoglycemia, you will consider that and not syncope, because syncope becomes a general statement which anyone can face. Anyone can face syncope on the dental chair. You, me, a normal healthy patient, a pregnant female, a diabetic patient, a patient with adrenal insufficiency. So that becomes a very generalized statement. But if the question mentions a specific condition that the patient is suffering from, then you think in terms of that. And like I told, hyperglycemia will not cause double vision. The double vision will be due to maybe the patient image has sudden drop of blood sugar levels and the patient starts feeling dizzy. The patient is going into syncope and the patient has double vision. So the thing is, please read the question, understand, and then answer. And we are available on WhatsApp groups 24/7 to answer your doubts, and on Instagram as well. All right, so you can ask our doubts and let us know. You can ask your questions in the WhatsApp group. We will try and answer and explain. All right, so I wish all of you all the very best. Happy studying, and you can always ask our doubts. And